let's turn to patients with an EGFR mutation who have exhausted the benefit generally of osimertinib or other EGFR inhibitors, this setting of acquired resistance. We have had a few options. We generally, once patients have exhausted what we think of as the main benefit of targeted therapy, we largely follow the pathways of what we would do for someone without a driver mutation. So we might consider the typical approach of chemo with immunotherapy, a drug like Keytruda, based on the Keynote 189 trial. These are almost always patients with an adenocarcinoma. But we also know that patients with EGFR mutations and quite a few of the other driver mutations don't tend to get much benefit from immunotherapy. And so this trial looked specifically at nearly 500 patients with one of the common EGFR mutations, deletion, an exon 19 deletion or an L858R substitution, and randomized them after they had received immunotherapy. I'm sorry, after they had received EGFR-based therapy and progressed to essentially a rerunning of the Keynote 189 trial of chemo, cisplatin, or carboplatin with Alimta, with either Keytruda or placebo. And then after several cycles, you drop out the platinum drug. And there was optional crossover in this. Now, here we had a press release, and we also had ultimately the data that show it's not a statistically significant improvement in either progression-free or overall survival. Now, as I discussed in some of the other settings, here the p-value is less than 5%, but due to the statistical details, it's not technically statistically significant even for progression-free survival, nor for overall survival. When you look at the actual curves, again, when a curve is on top, that represents an improvement over the other one, at least a potential improvement, but the degree of difference between the two arms, the space between the lines, represents how much of a benefit. And it's a little bit of a trend. It's not great. It's just a 20% improvement. If that, it's not enough to call it statistically significant. And overall survival, it's less than that. But the addition of immunotherapy has a suggestion of being a little bit better, but nothing that is, again, statistically significant. They did look at whether patients had PD-L1 of positive 1% or less, and if patients had less than 1%, really no benefit at all. It was more pronounced, although doesn't necessarily seal the deal, in the PD-L1 greater than 1%. So this was really, at the end of the day, called a negative trial. And my question to you all is this totally negative and dead? I mean, does this mean that immunotherapy adds nothing? Does it add for a subset of patients who maybe we can do better in delineating who would be the beneficiaries? There's also been some data in other trials that adding anti-angiogenic therapy to the mix could really be of value for these patients. So do you consider this a dead issue, or still one that is worthy of further study, and there may be a subgroup of patients who do benefit, and or adding anti-angiogenic drug like Avastin might be the next thing that needs to get done? Maybe if I can start with you, Alfredo.
Yeah, thank you very much. Personally, I think this is a good study. It's been, designed perfectly, and it is clearly negative. It's difficult to pinpoint anything that could be, any possible positive signal has been already explored. Is, we all know the PD-L1 positive here means not much. And so for me, I've always been a bit skeptical about immunotherapy in the specific subgroup, and this trial is confirming my skepticism. I struggle to see a future for immunotherapy in this population unless there's any different biomarker, and with really start thinking out of the box, stop thinking about PD-L1 expression or adding drugs randomly without defining the subgroup beforehand, I think we won't see the benefit, or we will see a very marginal benefit. But we have to, be aware that every time we had a drug, we had infusion, we had time, we had cost, we had toxicity. So we need to be contrabalanced, but a clear benefit. It cannot be a week or 10 days progression-free survival. Well, so I personally don't see any future unless we find some specific biomarker that I'm not aware of that could be used to identify that very small subgroup of patients that can benefit.
Christine, what are your thoughts? I mean, I don't think this helps the present, but do you see a future?
Yeah, I mean, I think it doesn't help the present. I think we don't understand the immune system, period. I think, what I see in the future for EGFR mutant lung cancer and immunotherapy is not maybe PD-L1, PD-1 targeting agents, but other types of immune-based therapy like CAR T therapies or engineered T cells or personalized vaccine therapies. Like, I wouldn't rule out immunotherapy altogether. It may not be these specific drugs. And so I think that there is a role for the immune system, for utilizing the immune system. We just don't know how to do that yet for this type of lung cancer. And so these agents, this PD-L1 targeting or PD-1 targeting agent in the context of EGFR mutant lung cancer has not proven successful for all patients. There's probably a small, very, very small subgroup that benefits. We don't know who they are. But I think in the future, there will be other ways to harness the power of the immune system for patients with EGFR mutant lung cancer.